in 27 people according to Dementia in India 2020 report. Nurses working closely with the patients play a key role in caring the patients with dementia. Today we are going to have a panel discussion on the subject NurseDem Dementia Care. The panelists for the discussion are Dr. P.T. Sivakumar, Professor, Department of Psychiatry, NIMHANS, Dr. A. Tirumurthy, Professor, Department of Psychiatric Social Work, NIMHANS, Dr. Elsa Sanantambi Devi, Professor, Mahe Manipal, Dr. Jyotsina Agrawal, Associate Professor, Dr. Sailakshmi Gandhi, Professor, Department of Nursing, NIMHANS. I welcome you all, ma'am, for this panel discussion. For this discussion, and also I welcome all the panelists along with the participants who have joined for us. In this discussion, we have the chairperson and the moderator, Dr. Anis Judge. Dr. Anis Judge is the Dean of Manipal College of Nursing and Professor of Child Health Nursing. She is a nurse educator, nursing administrator, researcher, and a registered nurse who value caring as a fundamental core of the nursing profession. She serves on the editorial boards of 5 peer-reviewed journals. She was an associate editor, associate editor for the prestigious Biomed Central Journal, the BMC Nursing. She is an approved PhD graduate of Manipal University and an expert member in the doctoral committee of various Indian universities. She has published more than 116 scientific articles in various national and international peer-reviewed journals. Welcome, ma'am. And ma'am, now I hand over the panel discussion to you for coordinating and for chairing the session. Thank you, ma'am.
Good afternoon to you all. Thank you, Kritideepa, for starting the program, and also I appreciate all the efforts you have taken during the past few days to see that this comes to a reality, and keeping all of us informed about that. I really appreciate your efforts. Thank you for the nice introduction. Dr. Sailakshmi, as she has mentioned to the panelists, we have learned together in College of Nursing, CMC Vellore. All the panelists I see are people who are some way or other involved into the geriatric care and for dementia services. I think I am the only person, odd person out, because I belong to child health nursing. So geriatric nursing and child health nursing, two extreme ends in human life. But being associated with the nursing students and the community, I am really interested to see to the welfare of the geriatric population. And as rightly mentioned by Kritideepa, our country also is entering into a phase that geriatric care is equally or more important than the pediatric care. We used to give a lot of emphasis in our healthcare system for MCH services and the child welfare services. Equal importance is now being demanded by the geriatric healthcare requirements because of the increase in the life expectancy and because of the increase in our own relatives and people living for a longer life. It has become essential that we focus on geriatric healthcare services. This increasing number is not only a problem for the geriatric population, as we all know. Equal burden is experienced by the caregivers of people with dementia also. So preparing the entire population to take care of our senior citizens, our elders, who have contributed so much to the growth and development of our country, it is our responsibility, I strongly feel. And this area is taken up by the nursing team headed by Dr. Sailakshmi Gandhi in National Institute of Mental Health and Neurosciences, a leading institution where a lot of developments are taking place in the nursing professional area also. I congratulate you all for taking up this. I have observed and heard from you that you are going to start a 1-year program. Um, Initially, my doubt was that whether there will be takers. I'm sure that you have really taken care of that concern, because what's happening in our profession is that once we finish the graduation or the post graduation, we feel that we have become experts in everything, whereas it is the other way. We have got sensitization to the various branches of the healthcare professional area only. Specializing and learning more about how to handle geriatric population, and especially people with dementia, has become essential. With this increasing number of people requiring care during their elderly stage of life, at Manipal College of Nursing, we have included a short course on geriatric nursing in our undergraduate curriculum from the academic year 2015-16. We thought that not an in-depth training, but at least sensitize our young professionals that this is an area which is becoming an area with wide scope, and many of them may have to enter into care settings where they take care of our senior citizens and elderly population. Having started with the geriatric care program, then we also started with an association which is registered. It's called the Geriatric Nurses Association of India. Just in the year 2018, we are hoping that we will become more active in that area. While congratulating the whole team once again, without taking much time, I take it as my privilege to introduce the panelists. The first speaker will be Dr. P.T. Shivakumar. He is a professor in the Department of Psychiatry at NIMHANS, and he is affiliated to Geriatric Clinic Services, Department of Psychiatry, NIMHANS. He is working as nodal officer for implementation of NALSA scheme for the senior citizens. And his areas of interest are geriatric psychiatry and healthy aging. I really appreciate that healthy aging part. Maybe we have to reduce the number of people getting with problems by supporting the population with healthy aging practices. He has published around 80 publications in various national and international journals, and has written 68 research papers, penned 2 chapters in books, and 10 other reports. He was principal investigator and co-investigator for 500 projects, and is the Vice President, Alzheimer's and Related Disorders Society of India, Bangalore chapter, and an executive committee member, Indian Association of Geriatric Mental Health. Very pleased to have you with us, sir, and I'm sure our audience will be waiting to listen to you. I will introduce our second speaker, Dr. A. Tirumurthy. He is from the Department of Psychiatric Social Worker, Professor, and former HOD of the department. He has 20 years of professional experience in the field of psychiatric social work, and is involved in teaching, training, research, and clinical activities throughout the career. His area of interest are adult mental health, geriatric mental health, palliative care, suicide, and stress management. He has guided a number of masters, MPhil, and PhD students in their research, and has worked in 10 funded projects. He has publications of more than 35 in international and national peer-reviewed journals. And he is also the member of various organizations like Indian Society of Professional Social Work, Indian Journal of School Social Work, Alzheimer and Related Disorders of India, Bangalore chapter, World Association for Psychosocial Rehabilitation, International Association for Professional Social Work, Asia Pacific chapter, and is a life member of Samaja Kairida Hejjagalu, Social Work Footprints. We welcome you also to the panel, sir. It's a privilege to meet a person with so much of elaborated contributions to the geriatric population in our country. Our third panelist is my own colleague, from whom I have learned a lot about dementia, and her enthusiasm has led the entire faculty group of College of Nursing Manipal to enter actively into the services for the geriatric population. Dr. Elsa Sanathambi Devi is a Feimer Fellow, Professor, and QMR at Manipal College of Nursing, Mahe. and she is also faculty at Feimer International Institute of Manipal Academy of Higher Education. She coordinates the first ILTS center in India in collaboration with NHS UK, and she is also a fellow observer under USIEF grant for 21st Century Initiatives to MGH Institute of Health Professions, Boston, USA. She is the recipient of University of West of Scotland fund to develop family and community capacity to provide evidence-informed advanced dementia care and reduce risks of dementia-related elder abandonment and abuse in India, which is becoming an increasing problem. Although we feel that our literacy status is increasing, people are becoming more responsible. We read from the social media the ill treatment which our senior citizens are receiving in different corners of the country. So she takes keen interest in preventing this and making people aware about their responsibility on caring for elders. She is an author of 3 textbooks and a freelance editor. She holds PhD in nursing, MBA in healthcare services, Feimer Fellowship, PG Diploma in Diabetes Education from World Federation, Hope Project, and PG Diploma in Guidance, Counseling, and Psychology. Elsa is a member of many professional organizations and has 60 research publications and is a Rotarian. Different from the academic side, she is the national level player in Kabaddi and represented the state of Manipur. Hailing from Manipur, her interest towards the Northeast. She is the project coordinator for Sanjeevani project for children with cancer from 2007 to 14 under the Voluntary Services Organization. Reflection, a booklet dedicated to Feimer Fellows. And she also conducts a skill workshop for community nursing officers at Manipur. Although now she's stationed at Manipal, she extends her services for the people who brought her up during her young days. With these few words, I introduce Dr. Elsa Sanathambi Devi to the audience. And our fourth speaker is Dr. Jyotsina Agrawal. Dr. Jyotsina is currently an associate professor at the Department of Clinical Psychology at NIMHANS, from where she had earlier completed her MPhil and PhD degrees. A consultant for adult psychiatry, positive psychology, integral medicine, and geriatric mental health services. She has also worked in various other teaching and research and management positions, and she is the faculty in charge of Vedic Indian Psychology Research and Application Division, under which she runs 2 clinics, Sattva and Swasthya, focusing on recovery from mental illnesses and enhancing well-being informed by yoga psychology. Her research interests include humanistic psychology, positive psychology, preventive and promotive approaches towards public mental health, psychotherapy, Indian psychology, yoga, and consciousness studies. She has several publications in the field and is also supervising Master of Philosophy and doctoral level research in this area. Subsequently, she was awarded Fogati Postdoctoral Fellowship at Washington University School of Medicine, St. Louis, and S. Vyasa Yoga University, Bangalore. I present Dr. Jyotsina to the audience. A lot of interesting areas you are touching. We are thankful to you for the services which you are doing for our fellow beings, and I welcome you to the panel. The last panelist is my own very close friend, Dr. Sai Lakshmi Gandhi, who is very well known to all those who are in the field of psychiatric nursing in our country and in many of the international areas. Dr. Sai Lakshmi is the professor and head department of nursing at NIMHANS. She is a consultant in psychiatric rehabilitation services and adult psychiatry unit. She has 35 years of professional experience in the field of nursing. Her areas of research interest are stress management, capacity building, and manpower development, child and adolescent health, school mental health, suicide prevention, rehabilitation for persons with psychiatric illness. She is a widely published author. She has published more than 150 articles in national and international indexed journals, authored 10 books and numerous book chapters, monographs, and IEC Ethical Committee materials. She is currently the principal investigator for 2 extramural funded and co-investigator for 3 funded multidisciplinary research projects. She has a number of awards to her credit, a very few which I would like to mention: the prestigious Florence Nightingale National Award by President of India for Best Nurse Educator in the year 2014, Dr. Radhakrishnan Gold Medal Award for Excellence in Individual Achievements and National Development by Global Economic Progress and Research Association in the year 2012, and the Florence Nightingale Award for the Best Nursing Tutor in Karnataka in the year 2009. Lot more credits to her achievements in the professional field, but without taking much of the time of the audience, we will start with the panel. I request Dr. P.T. Sivakumar to enlighten us on dementia care at NIMHANS. Over to you, sir.
Good afternoon, everybody. So, at the outset, I would like to thank Dr. Sai Lakshmi for conceptualizing this program, and I thank the chairperson, Dr. Anis Jar, for actually introducing us and starting off this program. Now, as the chairperson highlighted, the population of India is aging. There is a global population aging also is happening, and we are just starting to kind of focus more on elderly people now. So the geriatric unit at NIMHANS again has kind of similar growth. So the last 20 years we have been working, but the last few years actually there are a lot of activities. So and there is further development that is happening. So Krishnapa, can you share the screen?
Sir, I'm sharing it.
Yeah. Or you can make me as a co-host. I can share it from here.
Sir.
Yeah. So what I would be doing next few minutes is to kind of give you an overview of what kind of care for dementia we're doing at NIMHANS. So being a geriatric psychiatry service, we have been seeing a lot of persons with dementia over the last 20 years. And since it's also a multidisciplinary team, what we are having, you'll be hearing from my other colleagues who will be talking about various aspects of care that is happening both for the patients as well as for the caregivers. And we actually work not only for those patients with dementia, but also a lot of work in the community level to actually work on healthy aging as well as in terms of provide caregiver support and to promote say a lot of advocacy activities also we do. And yeah. Are you able to share the slides? Okay. So I think most of you from the nursing professional will understand that dementia is a condition which has significant cognitive difficulties where the person is actually having memory impairment as well as other cognitive decline, and which interface with the person's activities of daily living. There is some technical challenge.
I think current has later. So
is it, Dr. Salakshmi, are you able to hear me?
I can hear you, Dr. Shivkumar.
I think there is some problem. Kritipa, can you just make me as a co-host?
Sir, I'm making it.
I will just share.
Yes, we can hear you, but your slides, I think you haven't yet shared.
Yeah. Because they are trying to do it from other end.
Okay.
So please make me as a co-host.
I think they have to do it. I can't hear.
I think sir is not.
Okay, there is a problem. You are able to load it? Not opening, huh? Okay, here it's not opening, huh?
So just give me 2 minutes. You start up.
Okay. I think there's some technical. I'm sorry for the technical difficulties. No problem. We will. So the persons with dementia not only have problems in activities of daily living, they also have significant behavioral problems and psychotic symptoms. So globally, dementia is one of the important reasons why persons require actually institutional care, and also a lot of caregiver burden is there. So coming to the numbers in which because of population aging, there is a rapid increase in the numbers of persons with dementia globally as well as in India. There was a report by Dementia India report by RC and NIMHANS also was part of that. And that report actually projected the numbers, what is expected prevalence or time in India. So as of now, more than 5 million persons with dementia are estimated in India, which is projected to increase to nearly 14 million by 2050. So this is something like a phenomenal increase in the kind of numbers, and it is going to be very, very difficult to provide care unless we prepare the human resources required to care, also the support system and infrastructure that is required. Can you move ahead? Yeah. Yes. Yeah. Next slide. Next slide. So dementia is also associated with poor quality of life and severe disability for elderly individuals, for people who are having dementia, and also significant economic burden. Many of them have to actually leave their work and then provide care. The caregivers themselves would not be able to actually carry on with their normal activities. So that actually leads to a lot of economic costs in terms of lost productive capacity, and also in resource in countries with good resource of care systems, the care arrangements is one of the very expensive things for the countries. Countries like say Australia, UK, as well as many other Scandinavian countries, they provide a lot of community assisted rehabilitation services for elderly with dementia. And that is very, very expensive for the country, for the economy. They spend a very high amount of GDP to actually provide for this long-term care. So in India, most of the care, more than 90% of the care is actually provided by persons with the family members. And there is a lot of challenges in terms of how they are able to provide care to such an extent their dignity and quality of life is maintained. So the resources are quite limited, and that becomes a big problem. Can you move on to the next slide? So one of the main issues is about the care actually is limited by the treatment, available treatment, and there is a need for significant care and supervision. So these are some of the important issues why dementia is something which has significant burden, and these are the impact that that leads to. Yeah. 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 Yeah, move on to the next slide, please. Yeah. So coming to the population aging, so the current, the recent census estimation in 2011 estimated around 10 crores of older adults 60 years and above, which is projected to increase to 32 crore older adults by 2050. The recent LASI report, Longitudinal Aging Survey of India, Study of India report, which was released in last month, actually provides a detailed estimate of the problems related to mental illness, including the cognitive issues in elderly. They have actually studied 42. They have studied in all the states except for Sikkim. The numbers are available now, which actually kind of projects an alarming figures, which needs a lot of assistance, because many of them actually requires assistance for daily activities. Nearly around 40% of elderly above 60 have one or other deficits in their independent activities of daily living, so that they actually need assistance from somebody else to carry out those activities. So in terms of prevalence of dementia, the current estimate is around say 76 lakhs, which is further projected to increase significantly. So another main aspect is main important point to note is more than 90% of persons with dementia remain undiagnosed and treated. So it is often considered as normal for aging. These symptoms, if you ask them, they will recognize these are the symptoms, but they may not be considered as a problem, and they will be considered as a normal for aging. And people, the public as well as the professionals have very limited awareness And also training in terms of dementia care, even for the health as well as mental health professionals, is quite limited. So there is a lot of need to train multiple disciplines and health professionals who will be involved in the care. Now, when we come to dementia care, the domains of care that is involved is we need to actually provide comprehensive care, which ranges from acute care, where the person is evaluated and diagnosed, and subsequently the informal care, which is provided usually by the family members and the family caregivers. And there are also a lot of requirements for support systems like daycare, where the persons will be spending a time, and then the structured activities can be there, and in a supervised and safe and secure setting. And respite care, where actually the caregivers who are providing day in and day out the care can actually get some respite by having a break from the continued provision of care. And some of them actually may not be able to provide a quality care, and there may be a situation where the elderly who's living alone may develop dementia, or for various reasons the family member may not be able to provide care, and they may require long-term care, either at a home-based or community-based setting where somebody is going and assisting the person, or by staying with them or visiting them frequently, or an institutional care where the person is admitted in a residential care facility. And in the late stages, one may actually require a palliative care, where the concept of palliative care is quite well established in cancer, conditions like cancer. But in dementia, again, which is again a terminal illness in many of the neurodegenerative causes for dementia, the concept of palliative care is recommended so that their dignity can be ensured and their quality of life can be maintained without resorting to a lot of invasive procedures, which actually affects them more in terms of their quality of life. Next. So the geriatric clinic and services got established way back 20 years back. 1999 was the year of elderly, and following that, our Department of Psychiatry initiated this geriatric clinic in 2000, and we are already in the 20th year, and we have completed 20 years of service. And during this time, Professor Matthew Verghese and Professor Shekhla Bharat, who are the founders of this clinic, actually established a multidisciplinary team in collaboration with multiple specialties like psychiatric social work, clinical psychology, neuropsychology, and nursing, and including collaboration with neurology, where this field has grown in strength. And in the last 3 years, since 2017, it has evolved as a full-time dedicated geriatric psychiatry unit with several teaching courses started. Nearly around 3,500 new patients, outpatients, and 275 to 300 admissions we do every year in the geriatric clinic and services. In the last 3 years, we have started several training courses, and like DM course in geriatric psychiatry, and the postdoctoral fellowship course in geriatric psychiatry, fellowship in geriatric mental health care. These 3 courses are for medical discipline, where after either MBBS or after the basic psychiatric qualification, we provide specialized training in the geriatric mental health care. And subsequently, we are going to start now the geriatric mental health nursing, which is the main focus today, which this course is again post MSc psychiatric nursing. Dr. Sai Lakshmi will be briefing more about this course and the training programs, what we are planning. With the collaboration with the psychosocial, with the psychiatric social work and the psychology, clinical psychology, we have been running fellowship in psychosocial care for elderly course, which has already been running for the past 3 years. And we also have a plan to start a certificate course for the caregivers, the basic caregivers, who are the main kind of stakeholders who will be providing care, 24/7 care for elderly persons with dementia, as well as other elderly who requires care. So this is something which again is going to start soon. Next. So these are the numbers which the clinic has grown from over the last 2 decades, a significant increase. This is primarily to do with availability of a specialized service and also the population aging. More and more people are seeking help, and we need to actually scale up this service. Otherwise, it will be very, very difficult to manage, because unlike the population of children, the population of elderly is actually a growing population. And the projected increase, if you don't train enough number of people and build the capacity, it is going to be very difficult for less number of institutions to provide the care. Next. So the lot of work in terms of research also has happened. So you can click. So the publications in peer-reviewed journals on various aspects, psychosocial aspects as well as biomedical aspects, have been conducted over the last 2 decades, and several of them have been published in these peer-reviewed journals. Next. So the inpatients again is something which is increasing. We have to acknowledge that the current inpatient facilities are not really that elderly friendly. We need to actually develop. There is a mandate to, as per the Maintenance and Parents of Senior Citizens Act, every hospital has to provide for a 10-bed geriatric facility, and this is something like which is required to be developed. And NIMHANS actually has a ward, but we are actually building a new ward now for a 20-bed ward, which is under construction now. That will actually provide a state-of-the-art facility to provide care for elderly. As of now, we are able to utilize the existing wards and then provide as much as service as possible. The services of the geriatric services have been recognized in terms of awards, both the state as well as national awards. Next. So coming to the functioning of the unit, we have a multidisciplinary team, which primarily the core team comprises psychiatry, social work, clinical psychology, and nursing. We have consultations with neurology, neuroradiology, speech pathology, integrative medicine, physiotherapy to get collaborative inputs. I think this is something very, very important because the elderly patients with dementia have significant problems, and it requires input from multiple disciplines. And NIMHANS being a center where all these facilities are available, it actually helps us to actually do a much more comprehensive care. And so we have dedicated first contact outpatient services on a daily basis. We were running it for 3 days a week. With the COVID situation where elderly have to be provided as dedicated services on all days, we have actually scaled it up to daily outpatient services now in the last few months, which is going to be continued for future also. And weekly 3 days, we have a detailed evaluation and follow-up services where patients are being assessed on a very structured kind of evaluation. And also we use electronic records dedicatedly developed for this purpose, which is called Geriatric. And then including the cognitive assessments, there are specialized assessments have been developed by our team, and we are able to deliver those services using those things. And another important aspect what we have developed from the last 3 years, and particularly post-COVID, is about developing the geriatric telepsychiatry services. We encourage a lot of telepsychiatry consultations, primarily for the follow-up. We don't want people to unnecessarily come for a simple follow-up. And it is very helpful in elderly with dementia where there may be multiple caregivers who may be contributing, the multiple family members. And we have been selectively doing even for initial consultations as per now the telemedicine guidelines gives us some liberty to actually assess even for the initial consultations through video call. I think this is something which needs a lot of scaling up in the future, and which will go a long way to address the treatment gap as well as to improve the compliance, improve the adherence to treatment. So this will be very, very helpful. And another aspect what we have developed is outreach services. The home visits are very important because people above 80, 85, many of them are frail. They are not able to actually come to the clinic for consultations. So we have been able to make some home visits. We would actually require more support actually to make it as a regular kind of service where home visits are provided on a regular basis. So ideally, the evaluation for elderly with dementia, if it is done at a home, we can actually make out a lot of things, and then actually the intervention also can be planned in accordance with the situation. In developed countries like UK, this is the usual way by which it is done. Usually the GP along with the team visits there. Primary nurses actually play a significant role. So we hope that with the fellowship courses, we will be able to have more and more such outreach visits and home visits and organizational visits in old age homes where we will be able to provide care and provide consultations. And the inpatient services provides acute care evaluations, comprehensive evaluation and management. Some of the things what we are able to do with a dedicated team is more focus on psychosocial interventions. The brain stimulation, again, there are some patients where depression may be a comorbid condition in dementia. And also even for persons with cognitive impairment, like mild cognitive impairment or with dementia, we have been exploring the novel non-invasive brain stimulations like transcranial direct current stimulation or repetitive transcranial magnetic stimulation. These are some of the advanced interventions which we have been able to try out to provide interventions for persons with dementia. So another addition to our multidisciplinary service is about the Legal Services Clinic for Senior Citizens. In collaboration with the Karnataka State Legal Service Authority, we have established a legal aid clinic for senior citizens in the NIMHANS campus. Earlier, the service used to be limited only for the persons with mental illness, but now we have expanded the scope to for senior citizens in general, and many of them are benefiting because our patients actually have a lot of legal issues in terms of their property disputes or many various other services what they have to actually get. This is something the availability of legal professionals also helps us to provide that service. An online support group, one of our PhD scholars actually is working on this area and to develop an online support group for caregivers for persons with dementia. And again, this is something which was very helpful during the pandemic situation. We were able to reach out to caregivers and provide online interventions. Next. So recently, as you all may be aware, that United Nations has actually launched a decade of healthy aging from 2021 to 30. This is something in the last few years, World Health Organization has been working towards launching of this decade of healthy aging. In the next 10 years, the United Nations has appealed to all the countries, member countries, to work towards strengthening the services for elderly, both in terms of the change in attitude, like countering the ageism, as well as fostering their abilities to for independent living, promoting age-friendly community, as well as developing long-term care systems. So these are some of the aspects which are very relevant for elderly with dementia. So NIMHANS has launched this initiative called as Vayo Manasa Sanjeevani, which is aiming to promote mental health and well-being in older adults with the objectives like promoting age-friendly community as well as promoting awareness. So we have been doing every week webinars on various themes related to elderly care. And also we have actually developed networks with senior citizen forums. Already around nearly 10 senior citizen groups have been formed. They are also meeting once in a month or twice in a month to actually do a more close group kind of discussion. These discussions are facilitated by our professionals as well as trained volunteers. And we are also soon going to launch a tele-counseling initiative where many of the nurses or other professionals, after undergoing a training in our maybe an online training to provide psychosocial support, they will be able to provide some basic kind of tele-counseling or provide psychosocial support to older adults. This is something through an IVRS system we are trying to launch, and there is a work going on which we expect it to shortly be available. And we have actually launched a portal called vms.nimhans.in, and various social media channels we have started, and then these activities going on. And we invite all of you to actually follow these activities and then contribute to these activities. Some of you will be able to kind of spread this initiative so that we expect these things to be reaching a larger number of elderly people. And a lot of persons with dementia actually can, and caregivers can benefit through these initiatives. Next. So another important initiative what we are doing is kind of coming up with a residential care facility. Recently, we have got a funding from REC, Rural Electrification Corporation Foundation, to start a 40-bed dementia care center to provide rehabilitation and supportive care for persons with dementia and other chronic neuropsychiatric illness. And this is something which will be very helpful for us to implement behavioral as well as with incorporating traditional interventions like yoga, Ayurveda, as well as other novel interventions in a dementia-friendly environment, and to provide a holistic integrated care. Because the environment becomes a very, very important thing. And this will be very helpful for us to train people. So training is an important mandate for us. So as an Institute of National Importance. So training in person-centered dementia care for both the family and professional caregivers of persons with dementia is one of the important objectives what we are having. And again, a lot of innovations are required to actually help design the dementia care to a situation that is adaptable to Indian context. So this is something we are working with a lot of experts to come up with models which will be very helpful for the Indian situation. And this facility also can help in research particularly on non-pharmacological interventions and environmental modification. It can help actually our fellowship students as well as PhD scholars in nursing departments. So actually to take up this area as a interest and then do a lot of research using this population, using this facility. So wherein a proper work can be conducted in a systematic manner. Next. So this REC Center for Dementia Care, as I highlighted, is a 40-bed facility which is going to come up with, which will have a range of care like respite care, medium and long-term care, as well as palliative care. We are trying to design it as a dementia-friendly environment, and we will be able to use this facility to provide stabilization of persistent behavioral problems. Our idea is that we, as much as possible, will try to stabilize the patients and see whether the family member will be able to actually take back them and then provide continued care in the community. Because most of the persons, we don't recommend institutionalization as the kind of first resort because it's very expensive as well as it is not something very ideal. Only those people who are not able to be managed at the community level requires long-term care. Unfortunately, some of them require those facilities. We need to provide those facilities. At the same time, we also have plans to develop daycare services, an active aging center, and a training center for dementia care workers in the Sakalwara facility. What we have is an outreach campus of NIMHANS. Next. So this current stage is actually we once the center was launched recently, we also got a lot of interest in terms of support for this center, and we need a lot of support further to actually run this center. And already we have got some donations through philanthropic contributions from our own senior faculty as well as other individual donors. So this is something which is very, very important for us to sustain this facility in a effective manner. Next. So Professor C.R. Chandrasekhar, our teacher, actually contributed 1 crore towards this maintenance expenditure of REC Center for Dementia Care. And recently we had a visit, and then we had actually finalized this beautiful location, a resort-like location as a site for the construction of this facility. And this is the whole team there actually looking at the site inspection. So our future plans, we are already, as I mentioned, we are constructing a 20-bed geriatric ward as a part of a specialty block, 125-bed specialty block for the geriatric ward, which is going to provide an enhanced and elderly-friendly facility for providing inpatient care. And the main focus will be on strengthening the home-based geriatric mental health care services and develop community-based rehabilitation services. Again, this is something which is very important in our context. We need to provide, a lot of our people are living in a rural situation. 70% of the elderly are living in rural, and we need to see as to how to reach out to them, how to provide community-based services to promote healthy aging. Ayushman Bharat and the health and wellness centers is something which we are trying to leverage that initiative and then see as to how to integrate the mental health component, geriatric mental health component with the National Program for Healthcare of Elderly. And this is something which we have been working on with the ministry as well as with the health department here. And recently we have also got a project of which Dr. Sailakshmi is also part of. The main focus will be on training the caregivers, where it's a national initiative for skill training and dementia and mental health for caregivers of older persons. And this is something we are collaborating with the National Institute of Social Defense also for launching the certificate course for geriatric mental health and dementia care for caregivers, and also a certificate course on psychosocial support for older adults. Another major research project which is on the pipeline is an NIH funded project where India Enigma Initiative for Global Aging and Mental Health. Again, this is an approved project which some of the senior colleagues from my team, our NIMHANS Department of Psychiatry is leading those projects, where brain imaging research on dementia is one of the main focus of this project. Next. So I would stop here. Thank you very much for the opportunity. And we will take any discussions in the end. I presume I already we are running some late. I will hand it over to the chairperson to take the proceedings further. Sorry for the technical glitches. I hope some of the things have sorted out now. Dr. Sailakshmi, are you able to hear us? Dr.
Yes, yes, Dr. Shivkumar,
yes.
we could hear you and your slides were very clearly visible also. Thank you.
Yeah. there are some glitches here. We had some challenges. Yeah, Anis, please, I would hand over to the chairperson for taking it further. I think you need to unmute, Dr. Anis. Your voice is not audible. Can you please unmute, Dr. Anis? I think still it's under mute. Maybe Kritideepa, can you see whether?
Now it is okay. Now I think
Yes.
host had to unmute me.
Yes.
Thank you so much. Lot of information. We will welcome for questions and clarifications towards the end. So now I will move on to with the second speaker, Dr. A. Tirumurthy, who will be enlightening us on psychosocial issues of elderly with dementia. Over to you, sir.
Very good afternoon. I thank Professor Sailakshmi for giving this wonderful opportunity to speak about the common issues related to geriatric populations, especially the dementia care. And I also thank the chairperson for this panel discussion, Professor Anis George, who has consented to be the chairperson for this program, and other team members. Actually, I was thinking that it is a panel kind of discussion, so I'm unable to bring the reading materials, PPT. But however, I would like to, I will be able to speak about what is the psychosocial issues related to persons with dementia and elderly. We understand that the common kind of psychosocial problems the elderly faces, that psychological problems, generally we tend to speak about anxiety, depression, mental health issues, and the social issues is a vast kind of thing. If you look at the kind of challenges related to social issues are their abuse, neglect, and respect, and also the loss of support, lack of support from the family members, lack of cooperations, and other stigma. These are the major challenges which they experience when being elderly. See, when combining with the psychosocial issues which interfere with their day-to-day activities, functioning, all those things, naturally it affects their psychological well-being, social well-being, emotional well-being, and spiritual well-being. These are the major areas. For example, we often see that elderly being sexually abused, victim of domestic violence, and deprivation from the family members, and desertion. These are the common kind of things which we have been seeing it. As far as my knowledge goes, right from the beginning of geriatric services initiation, last 16 years I have been associated with the geriatric clinic and services. The common problem is other than the medical illnesses, the family is not supporting, the family is not cooperating, the family is not providing the material support. They are not showing any concern, love, care. These are the basic expression that elderly tend to express. And we used to always try to look at how we can help them to promote positive mental health in them. It is nothing but facilitating them to feel a sense of satisfaction through promotion of psychosocial well-being. The well-being is ultimately, we cannot prevent the aging process. We cannot prevent any kind of adverse events which are going to happen during the process of aging. But however, we will make them to understand, we will make them to accept the reality of the aging process and make them satisfaction and go with the whatever the family norms, culture, and the expectation by the family members. So our goal is to promote psychosocial well-being and to make them sense of happiness and better life, and also try to promote quality of life and quality of care to the geriatric populations. In this, while providing the services to caregivers, the simultaneously during the process of caregiving, the caregiver also experiencing lots of burden, lots of emotional issues, mental health issues, and also they were unable to cope up with the crisis situations. So our role is to basically make them understand. After making them understand, certain skills are taught, basically how to cope up with the crisis situations while giving the care, how to address their needs, how to address their concerns. As they keep giving the care or continue to give the care, leaving their personal, social, emotional well-being of themselves, it becomes a very, very challenging for them, and resulting in they also experience kind of the same whatever the persons with dementia is experiencing. That is particularly uncertainties, anxiety, depression, and sometimes they experience serious kind of stress, so resulting in even suicidal attempts. So these are the areas as a social workers address as a psychosocial issues. And finally, uh, we have different kinds of service provisions. Uh, when we will have a group program for the caregivers of persons with dementia, where we will collect, we will have a group meeting with the caregivers. We will make them understand about what is dementia, causes, how different skills at their level they can provide. For example, when a patient is not able to do the basic self-help skill, see, we will train the caregivers how to do the self-help skill for the patients. In turn, they will teach them, they will make them through different kinds of cognitive stimulation, different kinds of behavioral modification techniques, how to model, how to put the button, how to wear the dress, how to brush their teeth, and how to comb. Simple tasks are being given to them through modeling. When the caregivers are able to perform, then they will imitate, they will do. We will try to rectify some of the cognitive disturbances, particularly memory related issues. There are set of tasks which are assigned to make them learn about the how to make their memory difficulties to be addressed. So the family are taught here as a skill building. The other thing is that for the caregiver, there is a structured kind of program to deal with their day-to-day psychosocial issues or ongoing psychosocial issues or crises. The, we will teach certain skills for the family, but caregivers, particularly how to cope up with this kind of situation. What are the positive coping strategies that they can adopt certain kind of activities for them to distract or deviate from the existing crisis, or while giving the care, they may be experiencing some sort of distress. For example, we will suggest them to adopt certain spiritual strategies or certain recreational activities for themselves. Or sometimes we might recommend also the bibliotherapy. See, whatever, if a literate person who is believing in philosophy, ethics, and morality of life, we will suggest them, we will guide them, and give the information. At the same time, we will also place them in connect with the local networking system, so that the local networking system can contact them and provide the services at their doorstep. So which makes them very much the service is available, the service is accessible, and they are also not sacrificing their time, energy, or any kind of monetary kind of thing. So when the service is available in their home care kind of services, they will feel more happy that somebody professionals are coming voluntarily and able to provide services. So that becomes a very cost-effective kind of program for them. And also sometimes the advanced level, we will teach some sort of basic techniques about how to distract from the normal distress, particularly using the cognitive behavior therapy. These are the therapies, generally the psychologist who is well trained in psychotherapy techniques will try to, but we also will give some kind of input through them. And often there are certain situations we may not be able to understand very correctly. The patients may be having different stories, the families will have different stories, and in order to understand and provide better care and services, we will make the home visit. As Dr. P.T. Sivakumar rightly pointed out, home visit is one of the intervention by which we can understand what is happening in the family, the support, the facilities, the resources available to them, and how those resources are united or tapped, or how the secondary system and primary system we can bring together to help the persons with dementia. So these are the areas, these are the resources we can easily mobilize through home visits. And also, while giving the care, sometimes often we see that stigma. When somebody is having dementia, they will say that this person has, the family has a serious kind of a mentally ill person, where again, like any kind of serious mental disorders, here also the common issues is whether if I marry in that particular family, the children who are going to born, or whether it will affect the family, the generations, in terms of the having the same illness as a genetic, as we often talk about the genetic factors. So here they will be very particular about the genetic factors, also one of the roles here in any kind of illnesses, not only mental illness, but these kind of issues also will come. But that also we need to address. And other common thing is that property issues. When the children are there, the family, the parents may be able to given all the whatever the material resources or any kind of resources, property, all those things. Finally, when they become older, they left with lack of resources or sometimes no resources at all. So that kind of situations we will always we will educate them and try to help, if necessary, legal remedies also. That's where our geriatric care and services in demands, Dr. PT is coordinating KSLA and NALSA, through which we are trying to help them. So sometimes the other social issues are they feel that they become empty. We say that retirement syndrome or emptiness syndrome, when nobody is there and where they feel lonely, they are alone. So they don't have time to spend, though they may be having time to spend, but with whom to spend, and the quality of time, who is taking care of, they feel always that there is nobody to take care of them. They will long for love and affection, care, and other things. So such is the situations. Probably the structured kind of activities, structured kind of day-to-day activities will help them. For example, we can encourage them to involve in certain creative activities, or move them, or to contact their friends and other whatever the activities, social service activities with which they were engaged or used to engage in the past. So we will connect with them, identify them, and reorganize such kind of programs. So the welfare measures, sometimes the common challenges with which the common challenges we also face is that the related to the welfare measures. Though the welfare measures are very much available through the government policies and programs, yet while trying to reach the beneficiaries, lots of technical issues, and also they have to spare lots of time, energy. Sometimes the benefit is not full. Sometimes their effort is becoming waste. So all those things, it is not reachable. Most of the time they say that when they reach the government authorities for old age pension or disability pension. It is not such easily available to them. So we need to facilitate them, contact the respective authorities and speak to them and write a letter to them, or through that we will facilitate and make them provision available to them. So our target is, while addressing psychosocial issues, we start from the information support to end support, dealing with. Sometimes while reaching to the community, we need to see what is the requirement of the community. See, it's like a matching hypothesis, something you will try to give to them which may not suit to them. So we will always, whether individual family or persons with dementia or community, we need to understand and tap their, map them in proper way, that what is the need, real need for them. Sometimes what is the need which you are, what is the support you are providing to them may not be real need for them. It will not match to them. So you need to probably have a community need assessment through which that can be addressed. The addressing is through multidisciplinary approach always. See, for example, the concept of multidisciplinary approach is becoming very well established and very well appreciated in the community, because under one platform, every disciplines are providing care and support and services. For example, if you take a geriatric care and support services, psychiatrist is available to take care of the medical need, the psychologist available to take care of the psychological part of addressing their cognitive, whatever the stimulation. The social work part of is to understand, make them, counsel the caregivers as well as the families, and skill building them, instilling skill and creating a hope for them. See, these are the basic things are available, and certain skills and training and care, proper counseling services. The nursing care is very, very important, and how to handle such a person in smooth way. So all those things are available in one roof itself. So it becomes a very, very popularized kind of thing and well appreciated by the community. See, the years to come, I'm sure that now the Department of Psychiatry, through which the geriatric unit is well functioning, and also every professional support is very much contributed. Years to come, definitely it is going to be an international center of excellence for the geriatric care and services. And certainly, definitely, Dr. P.T. Sivakumar has shown lots of interest after his venturing into geriatric. It has reached so high, and I am so happy that now lots of research also being conducted. And if you look at the current researches which are going to study the psychosocial issues related to the persons with the dementia, we are having the online support group programs for caregivers of persons with the dementia as one of the topic, and wandering dementia patient and their caregiver issues, and how to build a capacity, how to train the staff working in the NGO sectors or institutional sectors. That kind of studies also going on. So many other studies, and how to promote the mental health literacy among healthcare workers. These are the areas which so far we had researched, and which shown that the comprehensive approach or comprehensive psychosocial services are very much effective in the treatment and management and rehabilitations of persons with dementia. I am sure that with these limited informations, probably we can have an interactive sessions. We will be able to interact and share our further knowledges. Thank you, ma'am.
Can you unmute me?
Yes, we are able to hear you, madam.
Now you can hear. Okay.
Yes.
Thank you, Dr. Tirumurthy, for the valuable information you have given and the insight provided to us about the psychosocial issues experienced by the elderly as well as their caregivers and the support which you are providing. Now we will move on to the third speaker. I welcome Dr. Elsa Sanathambi Devi to talk to us on home care aspects of elderly with dementia from the point of view of nursing perspectives. To you, Elsa.
Can see. Thank you very much, Dr. Anish Joas, my dean, my teacher, and my mentor, who actually pushed me through this dementia project which we have in Manipal. And a real honor to you, ma'am, for giving us a lot of support. And we have Dr. Sai Lakshmi here, one who is pioneer in dementia care, who is the head nursing in NIMHANS. I think right from the beginning of my project in Manipal, Dr. Sai Lakshmi was there with us. And it's very, very, very consoling to see someone always mentoring us through. And we also have Dr. P.T. Sivakumar, consultant geriatric care unit, and Dr. Tirumurthy, who just spoke to us, in a lump sum of how patient with dementia to be taken care. And we have Dr. Jyotsina, who would be sharing her experiences. And thank you very much for inviting me and to share a few things about how home care aspects of elderly with dementia could be, dealt in a very simple way. Someone rightly said, what you learn in the book and what you see in the reality is quite different. Yes, it is quite different. And so I think we need to embrace the simplicity of care and how one with a tender loving care for our elderly can move a long way. So I have just few objectives to look at how we can need the influence of and support of literature on home care aspects, analyzing the fundamental truths about dementia care, prioritizing the needs of the elderly with dementia, and also embrace simple care techniques which we can train the caregivers. Therefore, empowering caregiver in aspects of home care for elderly with dementia is a prime importance in our elderly growing. As Dr. Sivakumar has rightly mentioned that huge amount of elderly growth is there in India and globally, of course. And India being a developing country, and we seem to say that we are from joint family, but we are not in many aspects. So many times, as Dean Ma'am has rightly said, elderly are left alone sometime at home. And so what do we do for especially when they are demented? So you have two pictures out here on your left and right. On the left is what you see, and on the right is what they see. So patients with dementia, because of their entire cognitive impact of the cognitive changes and also the sensory changes and the environment, we have a lot of ways to support them so that they are given the comfort. The elderly are not looking at luxury. The elderly are looking at comfort, just the comfort. And so how do we give to this the kind of empathetic approach to this care is important for all of us. Now looking at the now looking at the approaches to decision making. Now treatment decisions for patients with advanced dementia should be guided with the goals of care and also the providers and patients, because we have healthcare proxies. Here, healthcare proxy is the person who legally can take a decision for the person who is demented and who is not able to take decisions. So keeping in mind the patient's preferences, because all of us have some preferences in our life and in our daily activities. So that preference is only to see that we promote comfort. And also if in case the patient has medical problems and needs mechanical ventilator, or if patient has infection and then antimicrobial need to be prescribed and given. So these are the things where we can bring them to their pre-acute illness status, so that patients can maintain their health to that state of even although they are demented. Now, in various studies, we have seen that more 90% of proxies stated that the goal of care was comfort. That's why I said elderly may not need comfort, may not need luxury, but they need comfort, love and affection, which Dr. Tirumurthy has rightly said. And this is the one area we are lacking in our society. Having said that, we are in, most of us, in joint family and thinking that our children will take care. This may or may not happen. So setting up standard care centers, like which Nimhans is already approving, and looking at the picture which Dr. Turmuti was, and Dr. Siva Kumar was sharing, was very, very enlightening, because you have big center to take care of them, and that would be a big relief for the entire family as well as for the elderly. So they could get a very standard care for them. So there's a narrative which says 80-year-old woman has 7 children who are all settled with good jobs in different cities. Each one finds it hard to stay with her, nor their kids accommodates their grandma in their homes. She is demented and unable to self-care. So family decides to leave them in an old age home. But in the meantime, chaos happened as decision from the different children they had differences of opinion. So one says, let's keep her with a home nurse in the old home. And the other says, let's keep in an old age home so that we don't have to worry. And the others are mute. So this is a woman whose 7 children, of whom she has taken care of every moment in their life through their childhood. And we need to reflect on to see, is that what we want for ourselves in some the later days to come, or should we give in to this type of attitude, or should we care for our elderly? I think this is a serious thought that we need to think of when we are growing older, because every day we are growing older, and we need to think what would be our steps and what would be our contribution towards elderly care. So looking at the 5 fundamental truths about giving care to a dementia patient, we need to accept support. So as Dr. Tirumuti was rightly saying, that we need to get help from others, help from family members, help from relatives, help from friends. We need to accept support, because it's hard. If you're alone to take care of one demented patients, it is impossible that one person will take care. It is highly impossible, because when they're in advanced dementia, you need minimum 2-3 people. So it's very hard, and therefore we need to accept support from others, actively empathize, because we need to understand and put ourselves into the shoe of that person. If you think and feel and get into his shoes and feel that what he would be going through, I think we'll be able to have a very positive feeling for them, and would give them love and affection. And the care that we've given with love and affection is going to matter a lot to the person. And also be realistic caregiver. Many times family members says that we are taking good care, but if the patient has incontinence, and if there are foul smell, they have difficulties. But when we know that to be a realistic caregiver, we need to know what strategies I can do in the midst of the best of the worst of the smell, or worst of the situation. How realistically I can care for my dementia elderly, or the dementia person, or my family member, or my mother, or my father, or in-laws. So dementia is rather more than a memory loss. Therefore, we need to plan for future. Some time back, when my mother was sick in bed, she was, when I go home, she used to prepare her clothes, white clothes, all she used to wash, and then starch and iron and keep. I was thinking, why are you washing this many white clothes and keeping? She said, I'm preparing for my death. Because today, if we don't talk about that, we don't plan for future. So what happens, suddenly if anything happens. But we don't also, there's a stigma if you talk openly about death also, death and dying. So this is what one individual also prepares, so that mentally they are prepared for the any upcomings in their life decline. So basic care, today I'll be focusing on the basic care aspect. The right side, you can see a woman whose hair is plaited. This is my patient's hair. Every day when you do her hair, she has almost 1 meter length hair. And then once I asked, Auntie, shall we cut little part of the hair because it is thinning down? She said no. So what we have to do is we have to plait the entire hair, and then we have to fall back and tie with the ribbon. The ribbon has to be either brown or black. That is her choice, because she doesn't want to put blue or red or white. So sometimes hairdressing may look very simple, but it's the desire of that, what they have been doing when they were young, and how they look, they will want to look like, and that is how they prefer. So we need to look at patient's preferences. So this is one area, looks very simple, but we need to do. And hair doing is very interesting to them, because it gives a soothing effect on the individuals. So when you do once or twice the hair, either in the morning and one in the evening, it should be a kind of relaxation feeling for the elderly. Bathing techniques. Bathing seems to be very easy. It is not at all easy because sometimes the patients, you need to maintain their dignity, you need to maintain their privacy also. So sometimes someone may want to have a shower, and someone may want to use a bucket and a mug, because if you look at India, people all people don't have showers in their bathroom. So they may want to use maybe a bucket and a mug, mix the water. And some in the villages, people want to take bath in the sun. They would like to sit outside and then someone giving them bath. These all practices need to be retained, and what they enjoy, we should allow them to. And we need to properly dry them up, okay, and then moisturize, but not deep moisturization also, because if they are diabetic by chance, no fungal infections would come in. So every day the patient has to be bathed so that they maintain their cleanliness. And this is very important, because to some Hindu cultures, without bath there is no prayer. So that culture may be existing. So we need to know the preferences of the individual, even for bathing and their spiritual practices. One thing is that good look factor. All of us like to look good, because whether all of us, others will be wearing the best of the dress, or we won't be doing light makeup, or we will not be putting a cap. See, someone want to put bindi, someone may want to put chandan, someone may want to drape a beautiful sari depending on the occasion. So wanting to look good is always there, whether you're old or young. So I think all of us need to appreciate what our elderly want to do. Not that I don't have time to do this and that, okay, but we need to also help them do that. Okay, we need to join with them, and then if they want to put bindi, allow them to put bindi. If they want to put chandan, allow them, because giving a mirror and giving the things requirement, I think they will do themselves, and this is how it makes them feel good. On the other hand, selection of clothes and dressing sense. This is something, dress is something very unique to all of us as a human being. Some of us would like to wear sari, some of us would like to wear tops, some of us may want to wear churida. But when a person is with dementia and in the advanced stage, it is rather very difficult. Therefore, we need to look at what is the most comfortable dress for the weather that is existing. Like in South, it is very hot, so you can't be wearing woolen. But somewhere in the north and the northeast now, it is freezing, -2, sometimes 2 degrees Celsius in the morning. It's quite, it's like worse than the refrigerator that we have in the south. So it's going to be very cold. So we need to understand clothing from that point of view, plus what they would like to wear, what colors, what design. Okay, but when we take care, if there is incontinence, we have to think what is the easiest way to, drape the patient or remove the clothes easily. So that way we need to select dress, and also keeping in mind their dressing sense. Now, looking at the care aspects, a lot of elderly with dementia are also with a lot of comorbidities like diabetes, hypertension. Sometimes some of them are additional. They'll have Parkinson's, and there are many chronic diseases. Wounds are very common among elderly. So fungal infections are very common. I recently witnessed one elderly who had fungal infection. Actually, it started with the diaper dermatitis. He's on diaper. So almost, if you look at the cost effectiveness, she uses almost 10 diapers a day. In the market, if you say 10 diapers, mean almost 500 to 600 rupees per day. So a lay person, a person who doesn't earn much, will not be able to afford also. In the sense, that is another side of affordability. On the other side, dermatitis, which is very common because of income. Sometimes you will not know when they have passed. 5 minutes, 10 minutes, it may be there. And then moreover, diapers are made up of outside part is plastic, so it's never comfortable to the elderly. Though it is minimizing most of our efforts in cleaning up frequently, yet it is it has one side effect, that is contact dermatitis or diaper dermatitis, which is very common. And one of the patient went in to have infection up to the ear, and we have to keep her on high antibiotics. So again, antibiotics, antifungals, okay, antifungals. It's very tough for the patient to come back to the to the pre-existing state of that before the infection. It took almost 2 weeks to stabilize. So we need to see that all areas wherever there is a places like where the area like the groin, the back, everywhere need to be checked. When after bathing only, whatever emollients are given, they need to be put. Any cream that is required, is prescribed by the physician, we need to apply them and keep them very neat and clean. And while looking at wounds, we need to also look at triangular wound assessment, because when we look at wound, we need to look at the wound bed, the edges of the wound and also the peri-wound, because if the wound is clean, or if surrounding is dirty, it's going to mean nothing much to the wound, so it get dirty again. So we need to assess wound. This has to be taught to the caregivers, whoever is the caregiver, either the family members or the paid caregivers. So dressings, most of the dressing, no dementia patients are brought to the hospital now and then. Only the caregivers will come even for prescription. Once they are being diagnosed, they are at home, no critical medical condition, they'll be at home. So we need to teach the caregiver how sterile procedures can be done at home itself, and also if they need dressing materials, from where to get this accessibility and the place of access should be told to the caregivers, and they should be shown a way where they can get the dressing materials and how to use it. And also we need to train them very, very vigorously, because unless you train them, see, in nursing or medicine, we take so many years to get ourselves trained. Still we are not equipped to everything unless you have a critical experience in that area. So you can imagine caregiver who is just 1 month old with the patient may have to learn everything basic, but it takes time from them for them. Therefore, as you have rightly mentioned, that training is a must, and it should be a very protocol based training for the caregivers. So diabetic food is very common. As I said, diabetes is, we are already diabetic capital of India is the capital of diabetes already, and almost too many are developing diabetes very early. And so in elderly, you can see, you can visualize yourself already. They may have thickened nails, ingrowing nails, and changes in the skin, changes and infections, because they have peripheral neuropathy. They may not realize that they have got infection. Only when there's a big wound, they realize. So we should also teach caregivers how to do a food assessment. And if there is a callus, and how debridement to be done, nail care seems to be very simple. But when it is a sick person and ingrowing nail and a thick nail like this, it is very difficult to cut. So we have to teach them how to soak the feet, and then how to cut it. Okay, the various strategies used to cutting the nail itself is a big procedure. And one more thing is that patients will have a lot of sleep problems. So sleep disturbance may affect up to 25% of people with mild to moderate dementia, but 50% of the people with severe dementia are affected by sleep disorders. So sleep disturbance gets worse day by day as they progress to their severe form. So dementia patient may experience the following, that is difficulty maintaining to falling off to sleep. So this is caused by some of the sleep cycle issues, side effects of some medications, and also other factors, maybe noise. Someone is watching TV or with loud noise, or children playing around could be another reason for them not getting to sleep. Sundown syndrome is referring to increased confusion, agitation, and also anxiety and aggression in the night. This happens. Last week, my patient, she did not even sleep for half an hour, because saying that I'm late for my train. So she was packing up the whole night. She removed all the bed sheets. She opened up the mosquito. Everything. She was packing up, saying my train is late. I'm late for my train. So this kind of confusions, disorientation and anxiety, aggression, everything will be there with the patient. So we need to understand day and night. For the patient, there is no day and night now, because many times they are very drowsy during the day, maybe because of the medication effects, and then they do not sleep in the night. They sleep during the day and keep awake whole night. So this could be some of the problems with the patient face, and also movement during the sleep. So, such as a restless leg syndrome, which is characterized by an uncomfortable urge to move the legs during periods of rest, or rapid eye movement or sleep, which is a sleep disorder, which makes people, act out in their dreams. Suddenly they'll shout, and then suddenly they'll say that he or she is standing there, going there, and they also associated with this. They also may have hallucinations. So these are some things the caregivers may be wondering what is happening. So we need to orient the caregiver and tell them this is the problem. So they need to understand. So breathing disorder during sleep, sometimes they may have sleep apnea. So this is sleep apnea affects almost 50% of all the patients with Alzheimer's. So strategies for sleep concerns, pain management. Elderly may have pain. So sometimes we think that pain is common among elderly, but pain should not be experienced so badly, because brain is very sensitive to pain. Once you feel the pain, even if you give medication, it takes time for person to reduce the pain. So pain medication, if it is there, it has to be given. Then soothing environment. So nice bed to sleep, and a kind of room that is soothing enough, some daylight to be in during the daytime sunlight. If sunlight is falling into the room, they feel a kind of comfort which elderly will have. Check on the medication for side effects. If they are, suppose if the patient has a lot of itching and they keep on scratching the whole leg, and sometimes physicians prescribe for say cetirizine or some of the sometimes they also give anxiolytics. So sometimes because of this, they may remain very drowsy and they may not do their physical activities during the day. So we need to engage them on physical activities during the day. So allow them to bath in the sun sometime of the day. So what I do is I have a patient whom I'm looking at, closely how they are progressing. So the caregiver takes them out in the morning, say before 9 o'clock, and around half an hour she'll be in the sun. Again, evening we take her out. We take her out in the evening when around 4:30, 5 o'clock, we used to take her out so that she can see the entire surrounding and also feel the environment and see the natural animals, trees, birds, all that. She will be able to recollect many things. Time scheduling for sleep, because if you allow them to sleep whole day, then they won't sleep at night. So it may be a short nap, limited naps to be taken during the day, and also to avoid stimulants during the day and also towards the evening so that they'll get sleep at night. And the simple thing to make us feel all good is like before the patient sleeps at night, if you give a nice foot massage, if you give a very good foot massage, wash the leg and give a nice foot massage, I'm sure the patient continuously will sleep for minimum at least 4 hours, which will be a respite care for the caregiver. So unless you sleep, you can also get frustrated. So these are some small steps which you can do to enhance the patient's sleep, good sleep. Not only sleeping, but good sleep, sound sleep is important for the patient as well as for the caregivers. So incontinence and toilet problems for dementia patients are major problems. So the person with dementia are more likely to have accidents because sometimes if you don't have a low lights or ground lights, the patient may move out suddenly from the bed and they may fall. Or so because of the urgency which they feel, they may fall in the toilet. And falls are very common among elderly already, whether you have dementia or not. But in dementia, again, they don't know where they are going around. So unless the caregiver is awake, they'll not be able to feel so. So some of the reasons why, some of the reasons are like not being able to react quickly, even though they have a sensation for going to the toilet, they may not be able to sense it quickly and move. So failing to get to the toilet in time, that is because of mobility problem. They may have to use wheelchair or they may need someone to move them out of the bed and to the wheelchair and then to the bedside commode or to the toilet. Not being able to tell someone that they need to go to the toilet because they are not able to say or they are not able to communicate. So not being able to find, recognize or use the toilet. So sometimes they may sit on the dustbin, they may sit elsewhere. So sometimes the caregiver doesn't understand the process of and so they get irritated because they pass wherever. I have a patient where in her advanced stage, what she does is she'll pass motion and she'll pace all over the wall. So by the time the caregiver comes, it's everything is on the wall. So it takes lot of time, your time to clean up the entire room, clean up the patient. This can be quite devastating to the caregivers unless they are mentally prepared for. So why people mobilize? Okay, mobilization as form of communication, and what could be the reason for that mobilization? So we need to understand when patients are moving, why they are moving. So sometimes because of psychological need or physical need, like feeling hungry, thirsty, they may want to take a glass of water, so they may move. Glass may not be next to them, they may start moving out. So we need to understand why they are moving. Environmental stimuli, that is loud noise, unfamiliar surrounding, puzzling and also dangerous stimuli, or shift change of nurse. So if the patient is in the hospital, every shift they get disoriented because new nurse will be taking care, or two caregivers are there sometimes, and one caregiver in the morning, one caregiver in the night at home. Sometimes they don't recognize the other one very easily, but if they really treat them very lovingly, empathetically, they really they understand who likes them and whom they love. That also is seen among the patients even though they are demented. Medical emotional condition, patient having pain, patient having UTI which is very irritating, or patient having constipation. Most of the time they are sitting down, so they usually have constipation. They may pass after 3-4 days. So you can imagine when a person passes only once a week, it's going to be quite difficult for the caregivers even too. And the longing for physical stimuli. So sometimes they want to go outside the house, but we need to know when they want to go out. We should see appropriateness of the daytime when they can go out, not too hot in the sun. So preferably in the morning and in the evening are the time then and which they can look at the nature, enjoy the surrounding, even feed the pets. If they have pets like dog, cats, they can still play with them. So pet therapy are very common in the West, and then they even keep around their pets with the patients so that they know how to cuddle, and then everything seems easy, but it is not. So caring for a patient, at least you need 3 people on average. It's very hard because you get also the caregivers get frustrated because of the caregiving. So sometimes there is a kind of aggressive behavior, or frequently we think that they're asking all the time the same thing they ask over and over again. That may be because of some infections or some illnesses, or patient has some depressive symptoms, or some other diseases, or effect of the medication, or loss of independence of personal power. I have been doing whole life this and now I can't do that. Feeling can be there, or the patient has a pain. That is why patient has kind of escalating verbal. Sometimes you say the patient is shouting, patient is screaming, we tell them. So we need to, there is an art of verbal de-escalation. So we need to decide if patient is appropriate for verbal escalation. So we need to engage in conversation, okay, and also note whether the patient is in active. The environment has to be safe. Whatever they have in their hand, they may throw sometimes. So you'll have to be careful about it. So ensure safety. So ensure that there is adequate backup, and also clear area of potential weapons. So there's not be any sharp objects near them, because they may injure themselves or they may injure you. So form relationship with the patient. So every time you go, you have to introduce. So whenever I see my patient, I tell them, this is Elsa. So I ask, who is he? This is Elsa. So they try to correlate and see and remember. So I have also seen over the years when while taking care of dementia patients, that they remember the most irritating person. That is not in the literature, but you can see that the person who talks to them maximum and irritates maximum, they remember very easily. So even they saw the aggressive behavior sometimes, but it's fine. You smile at them and show your empathetic approach. They are fine with it. Okay. So you need to ask what they like the most, what they want to be called, and how would they like to have help from you. All that, a kind of asking that will help. Use very simple words to them, okay, and no medical jargons there. Utilize interests. So identify patient wants and feelings. Agree as much as possible, and do not disagree with them and shout at them. Okay, and rather you have to reinforce them on what they want, and set limits. So speak matter of facts and facts, and also offer choices of behavior when asked. Whether you like to walk, or whether you want to go by wheelchair, whether you want to hold your hand here, or that you can be asking them. And one thing we need to do is we need to enforce or evaluate. So if aggressive escalation and violence seems imminent, withdraw, and we need to mobilize for help. So you can call family members, another person who is there, said, I'm not able to manage alone, can you help me? Okay. It's like a helpline that you have, coordinating the care altogether. So this is the art of verbal de-escalation when patient becomes little more aggressive and violent. So I think living with our dementia parent, we need to agree and never argue with them. We need to redirect and never reason, distract and never shame them, reassure and never lecture on them that I told you this, I told you that. Okay, reminisce. There is never say remember I told you last time. So they may not remember. So it will be shaming them. So you should never say did you remember. Repeat, never say I told you so, and ask and never command on the patient. So these are few tips which we can handle the patients very easily. So home environment modification, as I said, falls are the commonest problem there. So changing staircase to ramp. So there may be 2-3 steps in the house. So if you can just put extra this thing and then put a ramp, it will be easy, because you may have to walk down with a wheelchair. It's easy for the caregiver. So door with floor elevation. Sometimes we have a partition between room to room. So if there is a floor elevation, that part needs to be removed, because the patient may fall anytime. Sharp edges of the door or self-lock doors, door latch to be removed, and bed modification and side rails. So side rails, bed, if you get a very good quality bed, it is affordable to us, is fine, but common men will not be able to afford. So in their same bed only, if you can make a low bed and then make a side rail, okay, with plank of wood, if you put also is fine. So at least when they sleep, they don't fall, or suddenly get up, you will know. Or so what I do maximum time is, even in the wheelchair, I used to put a small bell, so that when they move, you will hear the bell. So at least if you are making a cup of tea in the kitchen and the patient is in the TV room, and you want to know that the patient is moving, we put a small bell so that we can hear. The moment you hear the bell, you know that she's moving around, trying to move. So we will know that. So some kind of reminders to be kept. And easy pathways inside the house, hazardous elements removal from the room, and also avoid chemicals in toilet. Sometimes they eat up soap. So you have to be very careful. No chemicals, soap or any liquid soap, anything in the bathroom as well as in the room to be avoided. Even hand rubs. Now everywhere hand rub. Even keeping hand rub, they may drink. So we have to be very careful with keeping of some of these toilet accessories in and around, or cream or whatever. We need to avoid keeping their accessible end. And home environment, in our country also, there are elderly people who live alone, or only the spouse, the husband and wife, they keep staying alone sometimes. And so we need to look at fire safety, because these are the areas where they get burnt, and also sharp object cut. So we can always modify certain knife or wear a glove and do it. And also medication safety, because this is the one area 50% of the elderly, 50% medication errors are expected to happen with elderly. And it happens the moment you have more than 5 tablets, the patient has. Even for all of us, not only for elderly, we also forget our own medications. So error doesn't mean only wrong medication or wrong timing. It means many other factors. So it is already said, medication management is one of the biggest problem that we face with elderly. So we cannot do any more trial and error now. And one publication which Institute of Medicine in the US has published, that is, to err is human. Yes, to make mistake, is a human being's tendency, but it is showing up that it is the leading cause of death in the US. You can imagine, if US has this many medication errors, what will happen to India? And among the top 10 list of causes of death, medication error is standing second next to sepsis. So we have to be very careful with medication errors. So in Indian scenario, a publication made by Dr. Girdhar says 5.2 million medical errors are happening in India. This is in the hospital setup. Then you can imagine in a home setup. We study nursing 4 years, and medical people study 5 years, and we still have problem learning completely about medication. And you can imagine a caregiver who just come 1 month. What are we going to teach? So we need to have a very structured program of teaching what at least the patient is getting. So this has to be very structurally taught. So WHO says also that medical error is the top 10 killers in the world. And so are we, as healthcare providers, healthcare professionals, with the amount of research that we do, are we ready to prevent these errors in the community level? Because dementia patients, all of them are not going to come to the hospital. Many of them are managed in the homes only, and therefore we need to re-strengthen the community, and we need to strengthen the family members and the caregivers, whether it's paid or unpaid. So medication compliance, we have a lot of issues, not only with dementia but with elderly. So caregiver training is a must. And side effects observation, we are never told. When patient gets discharged, we just tell them take this, but nobody explain, when you take this medication, these are the side effects that you can observe in the patient and report. Drug interactions is never talked about. So therefore, challenges are always more than ever. And the drug interactions, says, for example, if the person is having hypothyroidism, elderly, and also because of antibiotics prescribed, they may have pantoprazole, which is one of the proton pump inhibitors. We need to remember that pantoprazole actually lowers the effect of levothyroxine. So what happens at the end of the day is patient will show up all the signs and symptoms of low functioning thyroid functions are low, and so they'll show up all symptoms of aches, pains, and palpitation, everything, all symptoms of low functional thyroid status. So, but then we need to know that levothyroxine's effect can be totally lowered or nullified by pantoprazole. And it is rarely, we actually, when we take pantoprazole, we are asked to take at least 4 hours before food. Levothyroxine is also one early morning medication that we give. And these two medication has to be given for before food. So you can imagine the gap between pantoprazole and levothyroxine. So The patient has to be fasting at least 4 or 5 hours before the food. You can imagine if you get up at 6 o'clock, when will you have your breakfast? And they're too elderly, maybe with diabetes. So these are issues, and we need to talk, but very prominently on the caregivers, why this medication need time. So at least minimum 2 hours gap should be kept, though it is ideally set 4 hours. Now this is one of the one of the drug prescribed for one of my patients. She's having hypertensive, diabetes, dementia, and currently just 1 week back she had a lot of diaper dermatitis, and for which she was on antibiotics. So Listril already AC inhibitors are given. Euglim, glycomet, and Jalra is given because this patient is already last 40 years he's been having diabetes. Of course he's maintaining, but strict diet maintenance, now no exercise happening. So they have given all this. So one problem here is glycomet is one drug which is very big. So this elderly who has difficulty already swallowing, how to give this big drug is a big problem. So sometimes having the difficulty of giving this medication, sometimes patient party, sometimes they say that anyway we are giving 3 diabetic medications, so let us give one which is very difficult. So unless without access during this pandemic is a big problem because they cannot go to hospital, take them also. There's a fear of COVID, and so they don't go. And they said we have stopped the medicine first. I said, how did you stop? So we need to assess when they have stopped. One side sugar level is increasing, blood sugar is increasing, for which the patient is prone to infection. So I was correlating with the infection, and they stopped without telling anything. They have stopped one drug because it is hard to swallow. So we need to also look at strategies what this pharmaceutical company can do to make our elderly more suitable to some of these drugs which will be given. So I was reading through, looking at whether metformin will increase the risk of dementia. So evidences are saying that high dose for long period is associated with neurodegenerative disease and also dementia. So we have to be very careful. And today, the prescription issues with the psychiatric drugs are spoken about quite a lot in the research platforms, because many of these antipsychotics, when you give, they tend to develop dementia. So we need to understand if some of those psychiatric disorders can be treated in a very different way, whether we can reduce the rate of dementia developing in India. So caregiver, how we can empower to give a positive outcome. I look at 5 main areas, that is caregiver empowerment training, financial support, care navigation, workplace support, and also caregiving respite services. So caregiver empowerment is like medication counseling. As I said, we need to go protocol-based teaching to every patient caregiver or the family member, cooperate routine care. So it is not like one son will take care or one daughter will take care. If I have 5 children, all 5 children should help in a routine way. They can help, so that at least some respite is there for the constant caregiver who is staying with the parent. Peer support, friends helping each other, community support system, and so standard caregiver training program, which already demands your team is already taking through, and psychological well-being program for caregivers, because they'll get crazy out the end of the day when you take care of only that patient and patient in and out 24 hours. If you are with them, we will also have depressive symptoms. So to bring out of that, we need to have some psychological well-being. So I'll come to that in the next slide. Financial support, because there's a lot of amount to be spent on the assistive device. You buy a wheelchair, the common simple wheelchair costs minimum 10 to 20,000 rupees, but to a common man is going to be difficult. If you get with a remote control, it is 1 lakh rupees. No one can afford that, only except the rich people. So to the common people, it may become very expensive. Therefore, financial assistive devices to buy them, or home healthcare service, some devices, maybe a glucometer at home, a syringe pump at home, all these things needs a lot of money. So we need to know from where they can leverage. Caregiver training grants, family group financial support. So family can, even if one son is taking care of the parent, other children also can support in terms of, at least in terms of money, so that they can have a paid caregiver or some assistance, so that they can manage financially. Insurance system access. So during this COVID time, some hospitals do not accept patients with ESI. So it becomes very difficult. So they have to hunt around where they can get they can get some amount of financial support. Care navigation, that is informational referral system, which already demands you're doing it. Help blind, digital platform for access to facilities, and also end of life planning. This is the place we need to plan. We know that we are growing old. We also know that we are not permanent on this earth. So I think we have to prepare them so that mentally and physically and religiously they are aware about their end of life. And also workplace support. Some of us are caregivers in the home. So we need to also have little bit flexibility in the workplace when we understand that this person has say mother or father or in-laws having dementia, so that because they are already congested in their brain looking after the elderly in the home, and then when you come to the workplace, you are sometimes overloaded. They may get work-life imbalance may be there. So to have that balance, I think little bit of flexibility or unpaid leave can be given to them, or adapt and grow initiatives for employment facilitation. So there are some people in this COVID time, people were hunting door to door. People used to come and said, any work is that I can do. So there are job seekers. So you can actually adapt, train them, and then train them as good caregivers. And also caregiver respite services. These are specialized nursing home services. They care sometimes where you can admit your patient only during the day when you're going to office, and when you come back you can take. There are some daycare facilities. Night respite for caregivers, that is like at least 4 hours of shifts in between, so that one can sleep at least 4 hours, another 4 hours. So home-based respite care for care end of life. It's quite traumatizing when you see the patient is going down, and especially if it is your mother or father, it means a lot to you. And so we need to have families help or relatives help. So totally we need to engage. So elderly demented patient need to be engaged and engaged and engaged. So they are very cute, like it's like the elderly are like toddlers if you look at, and dementia patients are all more or less like a toddler handling them. So if you do a group therapy, they enjoy a lot, and if they're alone, if you talk to them and play with them, they do that. If you ask them to draw, they do something, but they still enjoy. If they have been doing the art and craft, they really enjoy. And this is my patient who writes all the slokas every day evening 5:30. Half an hour she'll be writing 2 pages of slokas here. So every day she keeps writing. So I give her notebook pen. She'll keep on. It is memorizing, and also it's a kind of treatment therapy which you can use. So they'll remember certain things. The alphabets they'll remember. They know to read, just to keep them engaging. And this is one thing, quilling, which I learned recently. And of course I do a lot of craft and things like that, assembling things. So patient party, this is for caregivers. So when we make quilling and assemble, there's some dried flowers and some garden leftover things. If you give some colors to that, and during the free time when you cannot give caregiving all the 24 hours. So some of the distraction that you give for the caregiver is making quilling and then assembling. This is not only to distract them and divert their mind, but also they can actually earn money out of it. So if you frame this, you can sell in the market. It's going to be very expensive. So they can caregiving plus distraction, their mind distraction therapy, as well as they can also make money out of it. So these are some of the things which they can learn and do, and then it keeps them really occupied. It makes them very happy and feel good, especially during palliation. So family time strategies and celebration. We should never stop celebrating, even if we have elderly, sick elderly. We need to celebrate. We need to celebrate Christmas, their birthdays. Every moment you should celebrate with them. So celebrate various events of the family, whichever. If you are Hindu, you celebrate your Hindu festival. Even Christmas. This is my patient who celebrate Christmas. They are actually Brahmins. They celebrate Christmas with me because just to make them feel good. And sometimes I take them outside the roadside and show them all the trees and plants and fruits, everything. So they really enjoy and say that this is it. It's kind of reorientation to her environment. So I think we need to socialize. They need to know their neighbors, reorient to their neighbors, and certain games we can play in the family like snake and ladder or play carom. All these things are possible. So I think we should do something where the entire family members also enjoy, like a kid with the elderly. So these are some of the things we need to enlighten the key. So my key message to the entire group here is nothing should stop us from giving quality care, and that should be an empathetic approach. And dementia care should be on the government agenda for accountability, because number of we see with the advancing medical facilities, we are enhancing the number of years of living for us ourselves. So we are going to live longer, but we don't want to live with diseases for longer. So quality of life is important. So we need to have it on the government agenda. People and allies, supply versus demand. So today we have a lot of demand, but supply may be less for the elderly. So we need to look at how to collaborate and facilitate facilities for the elderly. Education and training, that is home-based competencies, because demented patients are not going to come to the hospital unless they have a medical emergency. So we need to see that competencies are made for the caregivers at home. Medication safety, access, affordability, and error-free. services integrated approach to reach every nook and corner of the country, because not having, see, if you look at whole India, south is very developed in terms of healthcare, but if you go back to northeast or north, many parts, these healthcare facilities are not available even to common men, forget about only the elderly. So this has to be accessible to every group, and the information that is sharing success stories, building evidences, narrative frames, media, today social media has made a lot more easier. So I think we can connect, and then we can share our experiences, we can help each other, we can have open discussion. All these things are possible. So with these few slides, I acknowledge Dr. P.T. Sivakumar, the consultant geriatric psychiatric unit, Dr. Sairasmi Gandhi ma'am for giving me this opportunity, and my dean Dr. Anis George, and Dr. Tirumati and Dr. Jyotsina for sharing as a panelist. And thank you so much.
Thank you, Dr. Elsa, for the detailed discussion on the home care aspects of elderly and for giving us the tips on how to take care of them. Now we move on to our fourth panelist, Dr. Jyotsina Agrawal, to talk to us on caregiver well-being. Dr. Jyotsina, we welcome you to the panel. Dr. Elsa, you can unshare your.
Good afternoon, everyone, and thank you, Dr. Anis. After this in-depth presentation, I'll go a little faster.
Yeah.
I'll share the slide. Can you please give me the share screen option?
Here,
Got it. Okay, so I hope you can see. I'll be talking about caregiver well-being. So, as we have already heard from other panelists that how family caregivers are so important. In fact, they enable the family, the elderly with dementia, to stay at home because they care for them informally and take care of their basic needs and all. So this support, as you have just heard, that it's a very multidimensional support. It's like personal, financial, helping them in meeting their bodily needs, psychological needs. For example, listening to them, listening to their worries, reassuring them, and in the overall maintaining their quality of life. However, it can also have a lot of negative consequences for these informal carers, which can be feeling isolated socially, psychologically feeling depressed and anxiety is present. Physiologically, they are not able to care for themselves. Financial difficulties are there. And this support is, such carers have been found to experience very high level of stress, anxiety, depression, etc. Especially if there is poor coping style, then in the caregivers there is high level of anxiety, depression, distress, etc. is present. One of the reasons is also related to ambiguity about future. What will happen? How long this will continue? What all things I'm expected to do? How this burden will keep increasing? And this can actually lead to anger, frustration, and as well as guilt because they are feeling angry, they are feeling frustrated about caring for the person with dementia. People can also have anticipatory grief. So even before they have lost the person, they may start grieving about the person. But apart from that, there can be also ongoing loss of companionship because they are if a spouse is there, they are not able to have their spouse to talk to at the same level as earlier, or the children may feel that their parent is no longer there. Even if the person is there, their mind is not there. They do not recognize and all. Same way, there can be loss of personal freedom by the caregivers. They are not feeling as earlier. They can just step out of the house without worrying about who will take care of this person, this relative, and loss of control. And they can also have a sense of declining relationship because there is a difficulty in communication over the time. They are not able to communicate at the same level, and they feel that the relationship is now changing. There is presence of misunderstanding about patient's behavior. There are times when like a patient is doing something which is like socially unacceptable, and they feel that, okay, this is transgressing the social norms, which can actually lead to a lot of shame and difficulties. And people can start feeling bad about their relative also. And finally, there can be a belief that the person with dementia is actually losing their sense of identity or personhood. So although the body is there, this person who is my relative is no longer there in this body. So people can start feeling like this, the caregivers. And the stress and anxiety and all can actually be increased or affected by some of the factors, if you see. So one of the important area is like how a person thinks about and makes sense of their caregiving role and the situation they are in. So if someone thinks that, oh, I'm like, no, this is so unfair and so unpleasant, I'm burdened while other siblings are not taking care of the parent, then they may feel very angry and frustrated about it. On the other hand, they feel a sense of contribution and a sense of that, okay, now I'm getting a chance to give back to my family member. Then they may feel more comfortable about it. So how a person thinks, a caregiver thinks and makes sense of their role and this particular situation can influence. Along with that, there can be other demands of life, because like if a person is having multiple children, like there are other demands in life, or someone else is also ill in the family, or there are economic financial issues, there is a difficulty at the workplace. So all other demands of life can influence this, their sense of anxiety, depression, etc. Further, there can be things related to dementia characteristics and demands. So like depending on how how much of difficulties a person is facing related to dementia, at what level or what stage it is, and how demanding the caring is at this moment, how much the person is able to care for themselves, and how much the demand to the caregiver is there. It will influence how the response is there. Similarly, carers' own health, a caregiver probably might also be in the 50s and 60s. So if the person is the parent is in the 80s and 90s, so they can also be their own health issues and their own sense of emotional well-being, which is affected by independent factors, which can also worsen the situation and which can lead to more difficulties and more lowering of well-being. Similarly, how much support they are getting from other people, whether they are informally, if there are other family members who are able to step in, the neighbors can step in, or the professional caregivers are there, or some kind of system, or institutional support is also there, which is important. Similarly, what kind of carer-patient relationship is there? So many times we forget that a person before they had started having this dementia, they still had this they could have had a very bad relationship with this particular person. So a person's relationship independently of the illness can affect their how much motivated they are with the caregiving role, or what kind of difficulties they are facing. So if, for example, there was already a pre-existing communication difficulties between a young, son and the father, and then it has worsened after the father has dementia. So those things can actually lower the well-being. Further, a sense of self-efficacy or the sense of confidence that they can handle some of the issues. So if a caregiver feels that, okay, they do not have the capacity, they do not have the skills, they do not have the self-dependence to care for this person, then they will feel helpless and their well-being will go down. Similarly, about the future situation, what are the possible prognosis and what are the trajectories which are there, which can affect their well-being? So in such situation, we need to look into what is helpful. So having a coping which is acceptance-based is very important, where the person has understood and accepted the situation as it is, that okay, dementia will lead to these kind of issues, and they will be having these demands on themselves. instead of resisting and feeling resentful about it, if they are able to reach a level of acceptance, and then they are able to find solutions to the difficulties, which is more important. Similarly, developing self-efficacy related to caregiving domains. For example, okay, if they feel that, okay, I can take care of these many areas, so maybe daily caregiving, and maybe for other things I can take help, professional help and all, for example, medication and some of the other maybe paid caregivers, so they can know that what they can actually do about it and feel confident about it. Similarly, having emotional supports, not only just the people who can come and help them at times do their work, but also listen to the caregiver itself is very, very important. So providing emotional support and reassuring them, validating their concerns and difficulties is also important. Further, it also helps if they the caregivers can be also, if there is a possibility that they are having some difficulty, so identifying them and targeted psychosocial intervention can be provided whenever required, so that these caregivers also maintain their psychological health. They are out of depression or anxiety, because once they are out of it, that can actually delay the institutionalization of the patient also. So caregivers' mental health and caring for that is also very, very important. When we look into the psychosocial interventions, there are some things which are more important. For example, psychoeducational skill building, which can increase knowledge and competence, cognitive behavior therapy, which is focusing on increased problem solving abilities, behavioral management techniques, psychotherapy, counseling, etc., which is especially important when there is unmet psychological needs in the caregivers, and managing their responses to their relatives' behavior. So, for example, someone is feeling very, very upset about the person with the behavior of person with dementia, and then they are able to work about their own reactions and their own feelings and their own needs in the psychotherapy and find other ways of handling this situation. Similarly, enhancing support, which is in the family, in the peer groups, for example, support groups and all, as well as professional support, which would be very important. When it comes to cognitive behavior therapy, there is a focus especially on enhancing problem solving abilities, which is very helpful for caregivers. Similarly, behavioral management techniques, how to actually manage the difficult behaviors of the patient, is important. Psychosocial intervention further can be also related to positive mental health. For example, having yoga, finding time out for yoga, meditation, as well as positive psychology based interventions, where they are able to look at how with their gratitude, their sense of compassion, enhance their compassion, enhance their sense of appreciation about life, about other people and all. So developing positive emotions and all, those things can be very helpful in enhancing the well-being. Similarly, there can be other kind of interventions which are related to music, physical activity, exercise, etc., which is relevant and useful in this field. So I'll end with this one very sweet quote that wherever you go, no matter what the weather, always bring your sunshine. So many times there are clouds of difficulty, and importance is to maintain the well-being is that acceptance of that about these clouds, as well as able to find ways to rise above them and find that inner sunshine, which will help someone to maintain their well-being. Thank you. I'll be there for the questions and answers, which I can take up. And I hand over back to the chairperson now.
Thank you, Dr. Jyotsina, for that short and sweet presentation and giving us information about how to support and help the caregivers who, more than the dementia patient, become exhausted with the double role played by them. Thank you so much. And now we move on to the host, Dr. Sai Lakshmi, to brief us about the nursing aspects, the programs which you are planning, and give us the details about that. Dr. Sai Lakshmi, we welcome you.
Thank you, Dr. Anis. I think my all the panelists before me have made my work very easy for me, and I think I might finish even faster than Jyotsina. So I'm going to just talk about the scope for geriatric mental health nursing in the country. Sorry. So the outline of my talk is about why exactly geriatric mental health nursing is so important. So it would focus on various reasons like lifespan, mental health issues, and how can we as a nursing profession help, and a little about the fellowship in geriatric mental health nursing course, which is going to shortly commence at NIMHANS. Dr. Shivkumar has already spoken about it briefly. So life expectancy around the world, as we all know, has increased steadily. As per WHO, life expectancy at birth in 2016 was 72 years. And we are not, lagging behind much. If you can see in India also, it is 70.4 years. So the life expectancy has increased and the quality of life also has increased. These are definitely many reasons why there should be increased focus on geriatric population. There could be various reasons for the cause of increase in lifespan globally. It could be the decrease in the cause of the specific disease like communicable diseases, chronic respiratory diseases, non-communicable diseases, improvement in nutritional status in the elderly, and a very wide range of healthcare innovations, new treatments, and risk factor reduction. There's also improvement in management of cancers. In India, beyond these, we also have better medical treatment, immunization, control of tuberculosis, malaria, improved sanitation, sewage treatment, clean drinking water. So all this has definitely contributed to improved quality of life and improved lifespan. Mental health problems, there are quite a lot. If you see, depression affects 7% of the world's older population, dementia 5%, and anxiety disorders, substance use problems. We also have self-harm. We find that in India, we have substance use disorders, 27.5, 27.5 percent, mood disorders 3.5, neurotic stress disorders 3%, and schizophrenia and psychotic disorders 0.5%. And this is from the recent National Mental Health Survey of India 2015 to 2016. So this is 4 years back. I'm sure it might have changed now. Coming to the topic of today's discussion, incidence of dementia, worldwide we find that around 50 million people have dementia and nearly 10 million new cases every year, of which Alzheimer's disease is the most common form of dementia. So here you can see in India, and this is from the ARDSI 2018, we are somewhere here 5.3 in 2020, and it is expected to more than double, almost triple in another 30 years. So I think these are all very, very good reasons why the Indian Nursing Council and we nurses should focus on newer courses in the area of geriatrics, especially geriatric mental health nursing. The cause of mental health issues in elderly population, very briefly to touch upon, could be loss in capacities, a decline in functional ability, reduced mobility, chronic pain, chronic health problems, bereavement. Dr. Tirumurthy had also spoken about the empty nest syndrome. So drop in socioeconomic status with retirement. So these are all many causes apart from urbanization, westernization, maladaptive emotional responses, loss of physical mental capacities, loss of loved ones, loss of authority and importance, especially with retirement, the change of role which the person has to take, or loss of roles. So these all can lead to a lot of mental health issues, especially depression. So what can the nursing profession do about this? So there are, if you see in Western countries, there are many geriatric nursing courses. in universities like the Trinity University, Sheffield Hallam University, etc. In India, I am not very sure whether this is the only place, but I do know that CMC Vellore offers a 1-year post-basic diploma course in geriatric nursing. I don't think any other college offers such a course. The IGNOU also offers a 6-month certificate course in geriatric care. And today I heard from Dr. Anis about the brief program which they have introduced in the undergraduate course. So in geriatric mental health nursing, so far there are no courses in India. And having listened to all these presentations from the panelists before me, I'm sure that you would all agree the importance of such a course. So NIMHANS is starting this course from this year onwards, and in collaboration, Department of Psychiatry and Department of Nursing. And this course will provide training related to provision of nursing care for elderly with mental health problems. So the training opportunities are immense because it is, of course, multidisciplinary approach, and the trainees will get opportunity for extramural collaboration. They'll get their clinical clinical experience from the geriatric ward, from also the upcoming Dementia Care Center, which Dr. Shivakumar spoke about, which is going to, already the plan for it has started constructing this at the Sakalwara Community Mental Health Center. I won't talk much about the geriatric clinic because Dr. Shivakumar has already spoken about it. So the implications of this course are that in the country, we would have a pool of qualified, specialized nurses who will work to reduce mortality, morbidity amongst older persons. And I feel that, we should keep at a pace with the Western country and look at super specialization. I think it's very important that nurses look at super specialization, and towards that, the geriatric mental health nursing would definitely help. Nurses with this qualification can contribute a lot towards the health of older persons as leaders in the upcoming Ayushman Bharat well-being centers in the country. So we would also have a generation of future teachers, clinicians, researchers in the area of geriatric mental health nursing. The trainees would have a lot of course benefits like case management, home visits, individual family therapy, caregiver interventions, group therapy activities, online support group for caregivers. Dr. Shivkumar spoke about all these, so they could participate in all this and get first-hand experience in the tele-psychosocial interventions, the legal service clinic for senior citizens, and how to train volunteers in psychosocial care of older persons, training of geriatric caregivers. So there would be collaboration with non-governmental organizations, and there would be also a small training in research methodology. So as I said, it's a little unique, different way of teaching, and hopefully the clinical experience which they gain would be really immense, and help them to deliver care to the older persons. So with this, I would like to conclude telling that this course, the eligibility for this course is MSc Psychiatric Nursing, and we have looked at giving a stipend of 25,000 per month. The total number of seats are 2, and the mode of selection is an online entrance exam, and it's already available on the NIMHANS website, the prospectus. So you can go through the prospectus and see whether you or your colleagues would be able to apply for this course, and also spread the word around further to other people in the country. So the online entrance exam would focus mostly on issues related to aging and mental health. So with this, I would like to conclude. Thank you for listening patiently. Thank you.
Thank you, Dr. Sai Lakshmi, for giving us the details, especially about the fellowship program. I'm sure that this will be a motivation for the young nurses to take up for the future. We are a little beyond the time plan which we have made, but still I would like to give some time for the participants if you would like to ask something or to clarify with the panelists. So I request all the panelists to be on the screen so that participants can clarify their doubts. Anybody would like to ask something? In chat box, I don't see anything, so that's why I said if anyone would like to ask, you can now ask, unmute and ask.
While we are waiting, yes, somebody is asking. Is anybody is raising the questions? Okay, while we are waiting for anybody to chat, or I think they can raise hands, no? They can raise the hands. Can you
I'm not
enable
able
them
to see
screen?
on my screen. Maybe
Can you enable them?
Deepa will be able to.
I think there's some technical challenge they're having.
Nobody is raising the hand actually. Nobody has given any questions in the chat box.
Oh, yeah.
I will just.
Time is out. They want to.
I just want to add this thing when Dr. Salakshmi mentioned about the prospectus already being available. I think there's some delay is happening. I think it should be up anytime. The new prospectus should be up anytime soon in the next few week or so. I think they can actually follow the NIMHANS website for further information. I think you can actually, if anybody has any questions, they can actually chat or they can raise a hand. Nobody is. There's still a lot of people.
No one has raised a hand or nothing is there in the chat box, which I checked.
Okay. So
I think because we are a little bit delayed, people would have planned some other activities after 4 and they would have left.
people are
there.
People
They
are
are
there.
there.
There are around 48 people still online.
Yeah.
Yeah, anybody would like to
Yes.
ask anything, they can ask. Yeah.
Which
Maybe
made-
I think
which made them very clear about for not asking any questions.
so much of presentation. Any of the panelists would like to ask anything? I think.
Yes,
we
sir.
can-
Since no one is asking, so let me ask one query. Now, the fellowship program is open to only psychiatric nurses. So, will it be open for any other specialty who are interested?
Yeah. So actually, this is a program which is jointly in collaboration with nursing. As per our institute regulations, the eligibility criteria is MSc Psychiatric Nursing. Also, there is a sponsored seats are there. Actually, apart from the 2 seats which are institute funded, there are 2 sponsored seats are there. So apart from this, I think I had also mentioned about a couple of certificate courses. Those courses which are for psychosocial support, I think that is open to anybody. I think that is not only for nursing, that is for all the disciplines. I think so. Some of the students who are enrolled in the undergraduate nursing courses, these are going to be online courses. That I think psychology, social work, nursing students, it may be of interest to them, because that will have content about psychosocial support and which will be delivered online. So that course is yet to be launched, but we are expecting to launch it soon in the next couple of months. So in collaboration with National Institute of Social Defense. So this program, the nursing fellowship, is actually for post-MSc Psychiatric Nursing.
This question is now you have a big center where you are going to have geriatric care, especially for dementia. So, is there any opportunity for Manipal to have a sub-center where we can also do some activities?
Yes, I think we would like to actually collaborate with multiple centers where this initiative of training can actually be extended to a large number of people. I was telling about an initiative where we are training the geriatric caregivers. There actually the plan is to collaborate with other centers of excellence. So that the training of caregivers can be done at multiple districts and multiple areas across the country. This again, we want to kind of promote it as a national initiative, of which I think Dr. Salakshmi is one of the very important partners, team members in this initiative, which the National Stock Exchange Foundation is actually providing us support to start off as an initial training. At the NIMHANS, we are going to have a in-person training and also an online training where after 3 months of residential training, online support is going to be provided. this training program definitely needs to be expanded to other centers. I think where centers like yours, which has expertise in nursing, can definitely be a partner to collaborate.
Thank you very much, sir.
I think there's a lot of need for geriatric caregivers with the training in geriatric mental health and dementia care. So that will be very, very helpful because many times they may not recognize as dementia, but having the skills will help them to actually provide some care with the understanding of the issues related to dementia.
We are already having researchers to start taking care of caregiver training. So it will be only for research and there will be some limitations. So if we have collaborative brands like yours, then we'll be able to give to the mass. So we'll be able to cover a wide range. So that's what that's why I was asking for it. We have lots of patients coming in, lots of dementia patients coming in.
We can explore collaboration, definitely. That's, I think, this initiative for today's program itself is a part of that collaborative initiative where Dr. Salakshmi has reached out to partners so that we can actually network with organizations like yours so that in future we can extend the collaborations. I think our team is Dr. Jyotsina and Dr. Tirumurti. I think everybody are experts in their field and they have been working in this field for quite some time. Dr. Jyotsina has been working in positive psychology and Dr. Tirumurti has been working with multiple issues related to geriatric social work, and Dr. Psylakshmi has been leading the initiative of nursing and as well as rehabilitation nursing and geriatric nursing. So the multidisciplinary team, what we have is our strength, and I think I take this opportunity to thank the entire team members for supporting all the collaborative initiatives.
I think now, since the participants have not much to clarify, we will wind up the beautiful session we had this afternoon about dementia and geriatric care, the need of the hour in the healthcare professions. I thank all the panelists for the expert sharing of your resources and also the your suggestions on how to help the geriatric patients. Each one of you had been an expert in your own field. It was wonderful to have each one of you to share your thoughts with our valued participants. Once again, I thank Dr. Psylakshmi for organizing this, and I wish you, Dr. Psylakshmi, all the best for the fellowship program and all the good wishes to the team from NIMHANS, Dr. Sivakumar, Dr. Tirumurti, and Dr. Jyotsina for the wonderful work which you are doing. I hope that the Sakalvara Care Center will become a reality and it will increase the bed strength and more people will be able to get the support through that center. Have a nice evening. Wish you all the very best. Thank you.
Thank you very much.
Yeah, thank you. Lily, before you give your vote of thanks, Dr. Annis was wondering why we called her as chairperson, being from child background. But I just wanted to tell her that, you know, old age is a second childhood. So I think we have called you correctly.
And I am entering into that second childhood. So right.
That's nice. That's nice.
Thank you. Okay, Lily, you might go ahead. Thank you.
Good afternoon, all. On behalf of NIMHANS, I thank Dr. Annis George, Professor and Dean, Manipal College of Nursing, for her active participation by chairing the session and moderating the interactive panel discussion. It is great honor to thank Dr. P.T. Shivakumar, Professor, Department of Psychiatry, Consultant Geriatric Psychiatry, for enlightening the group on burden and impact of dementia patients, growing population of dementia, prevalence, comprehensive care, geriatric clinic and services and the courses that are available in NIMHANS and bed facility, and the future plans for dementia patient at Sakalvara, and also about the comprehensive care, and also for all his support to all our departmental activity. Thank you, sir. I extend my thanks to Dr. Tirumurthy, Professor, Department of Psychosocial Work, for highlighting on psychological, social, emotional issues, family and caregiver issues, and the comprehensive psychosocial approach in promoting psychosocial well-being and improving the quality of life. Thank you, sir. I am very grateful to Dr. Elsa Sanatombi Devi, Professor of Medical Surgical Nursing Department, Manipal Mahe, for her detailed discussion on home care's aspect of dementia patient and living with the dementia patient. Thank you, ma'am. I also thank Dr. Jyotsina Agrawal, the Associate Professor, Department of Clinical Psychology, Demands, for narrating on multimodal aspect of caregiver well-being, factors influencing them and helpful to them, and also psychosocial intervention. Thank you, ma'am. My heartfelt thanks to Dr. Sailakshmi Gandhi, Professor and Head, Department of Nursing, who had focused on lifespan mental health issues of elderly in India, incidence of dementia and causes of mental health issues in India, and the courses that are available in India to deal with the geriatric problems. Ma'am, thank you so much for your continuous guidance, enthusiastic motivation and support. I also thank Mrs. Kruti Deepa for her active involvement in coordinating this program. My special thanks to Chandan, IT Cell, Mrs. Sindhu and Mr. Chandru, Biomedical Department, for their unclinching support and coordination. I thank all the participants. With this, we wind up today's panel discussion. Thank you, one and all.
Thank you, everybody.
Thank you. Thank you. Bye. Bye.
Thank you. Bye. We can end the session. Thanks.